Thanks so much for giving me the last talk. I appreciate it. No. So what I'd like to do today is go over a variety of concepts associated with metformin. How many of you use metformin on a fairly regular basis? Interesting. So let's work on that. So my entire salary comes through the UBC Faculty of Pharmaceutical Sciences. I do some legal work. I do a little bit of educational work. Please stop using aminoglycosides. I have received no honorarium or research money from the drug industry in the last 25 years or so, not that there's anything wrong with it. And I do a weekly podcast, as was mentioned, and would love it if you check that out. And I also make some iPhone apps and iPad apps that don't make any money, but there you go. So that's me, and that's if you're interested in any of the stuff I do, those are the websites that you can find me at. One of the fun things that I kind of like to do is I like to take popular music and reword it and re-lyric it and re-perform it. I thought I'd just show you the most recent ones that I put out, and then we'll get to the topic. You probably heard of the concept of choosing wisely. And so you probably also know the song Happy, and it goes like this.
Now we're choosing wisely, and you will advance, can do more harm than good. We're choosing wisely, imaging for minor things that may not give you the truth.
So that's all. Yeah, thank you. So that's all about how do you choose wisely, and I've got a whole one on type 2 diabetes if you're interested, and you can go back to that later. And then the most recent one I put out was to do with overdiagnosis, and you might get a kick out of this, and you probably do know the song.
Now you're leery, you've just been scanned, those fears within your eyes, incidentaloma.
The fact that I get incidentaloma into a song should impress you. Okay, so those are available to you if you want to check those out. So metformin. I've always talked about it, taught about it, that it's sort of the gold standard. And what I'm going to do is give you a presentation based on the sort of evidence that I could find. And you're all fully aware of this evidence pyramid. We've all seen this. But I'm sure most of you follow the thing that's at the top, which is this: I just know. An interesting concept when it comes to evidence. So we'll put it into context. So metformin is routinely mentioned as the gold standard. And one of your jobs in this talk is to tell me the name of the band.
Then I saw her face. Now I'm a believer.
So that's the Monkees. That's what they looked like then, and that's what they look like now. One of them's dead. So we all have a thorough belief that metformin is contraindicated in people who have renal dysfunction. It says so in the CPS, so it must be true. It's so powerful a belief that, in fact, as renal function drops, your use of metformin drops. It goes from 80% or 90% down to about 20% in people who have poor renal functions. So you're doing the right thing according to the sort of contraindication. But is it based on the best available evidence? So a few years ago, myself and Hugh Tilsey, who's an endocrinologist here in town, we published an article that looked at metformin's contraindications, and we weren't really able to find great evidence about this. And in fact, even if it was real, and even if the increased incidence of lactic acidosis went up by tenfold with poor renal function, the theoretical benefit that we've seen with the UK PDS trial would still well overwhelm the potential harm that's associated with lactic acidosis. So what I thought I would do is show you that. And by the way, this is a talk that I just gave to the Diabetes Directors Association, which was an interesting concept. So what I thought I'd do is just very quickly give you new information that's come out since that time. So that was 2005 or so. There's been a Cochrane review of this specific issue just recently published, and they basically say there is no evidence from prospective comparative trials or from observational cohort studies that metformin is associated with an increased risk of lactic acidosis. So it's fairly clear that it isn't. A very recent review in the JAMA 2014 also came up with a very similar concept because they're looking at the same evidence. There really is, based on at least randomized controlled trials, there is no evidence that it produces lactic acidosis. In fact, they couldn't find any cases in all of the studies that have been done. Now, what's interesting is there are some conflicting data when it comes to cohort data, but even then, even if it's real, like I tried to suggest, the incidence is so small that the benefit in theory outweighs the risk. And it's roughly somewhere in the neighborhood, if it is real, about 10 per 100,000 patient years. Now, there's no doubt that in overdose, it clearly does cause profound acidemia. So in overdose, it's clearly a problem, but and there likely are reports and cases of lactic acidosis associated with metformin, but the incidence is so low that I think we can relatively ignore it, other than for maybe a medical legal thing, and I could talk about those issues later if you'd like. The nice thing about it is that our ability, if it does occur, the mortality associated with it has dropped over the last number of years from about 50% down to 25%, so that's somewhat encouraging. So how do you do dosage adjustments? I'm sure you see people who have poor renal function on metformin. It's not that difficult. All you have to do is understand this graph. And it's a very simple concept. No, I'm just kidding. I just put that up there because nobody knows what to do with metformin. There are no studies to guide us. So all you can use is just common sense and some principles. So how do you think about it? It's 95% renally eliminated. So as you should do with all drugs that are renally eliminated, you should, if their estimated GFR is greater than 60, you probably don't have to do anything. If their GFR is between 30 and 60, you probably reduce the dose by about 50%. And if it's there, you reduce it by 75%. Is that right? I don't know. See the thing at the top? It's I just know evidence. There isn't any guidance, and there are many people who make comments on this sort of issue, but nobody knows because we don't really have any studies. But this seems like a reasonable approach. Here's what's interesting, at least contextually, for what doses you should be using of metformin. Metformin monotherapy reduces A1C by about 1.1%. If you double the dose, you get an additional 0.25 to 0.3% change in A1C. So just as with any other medication that we've ever had, doubling the dose really doesn't give you much greater benefit. Now, when you look at is an additional 0.25 to 0.3 change in A1C even clinically relevant, it's certainly not, you certainly can't pick it up. The A1C test is not accurate enough for you to pick that up, and most people don't even consider that a clinically important difference. So if you are nervous about using metformin in general, or if you're worried about the doses, I think the easy way to do is just never use more than about 1,000 milligrams, because you don't get much greater A1C benefit anyway. So that's just one attempt. And again, is this evidence-based? It's evidence-based in that that's how big a change you see in A1C, but the recommendation is, again, I just know. And it's an interesting thing to put it into context. So if you're just worried about using metformin and lactic acidosis, even though you don't have to, just use 1,000 milligrams and never go much above that. Here's where it gets tricky. So I want to talk about the actual benefit of using metformin. One of the things is that we describe diabetes as the silent killer and things like that, and I think we need to put it into context. So there is no doubt that as glucose goes up, bad outcomes get worse. Nobody will deny that, nobody refutes it. What they will refute is, if we reverse it, do we get a benefit? And this goes back to what some of the things that Tracy was saying earlier on this morning. The best way I have of being able to show you what the risks associated with type 2 diabetes are is this way. Tom Hanks was recently diagnosed with type 2 diabetes about a year and a bit ago. And if you were to use the best risk engines that we have, things like UK PDS and so on, this is how you should describe the risk of type 2 diabetes to Tom Hanks. And I sort of made up some of his numbers, but they're pretty close. As your A1C goes, you can see on the bottom thing, that's A1C 5, 6, 7, 8, 9, 10. This is the 10-year risk of cardiovascular disease as his A1C goes up. So instead of telling a person they necessarily have diabetes, what you should be doing is saying, if you're, for every 1% increase in your A1C, your 10-year risk of cardiovascular disease goes up by about 2%. That's the absolute increase in risk associated with type 2 diabetes. Now, he also played a woman on TV in Bosom Buddies, and that would be the risk if he was a woman, which I'm told he's not. It's a little bit less, but again, there is an increased risk of cardiovascular disease as that goes on. What's really kind of interesting is this would be considered normal. So this is a normal A1C. The poor people who actually live and ingest and actually have glucose in their bodies are now being given the diagnosis of prediabetes. And what that means is your risk has gone up by almost 0.5% over 10 years. That's what being pre-diabetic means. And then this is the rest of the people who have type 2 diabetes. This is about 90% of all the diabetics that you will see, so that almost all of them are, have an A1C less than sort of 9. And this is about half of the type 2 diabetics. Now, it's tricky information because some of these are treated, but these are not necessarily all treated type 2 diabetics. The mean A1C is around 7.2, so we're seeing a lot of people being diagnosed with type 2 diabetes with with lower A1Cs than we ever used to because the guidelines have changed. And we have targets where we try to get people to less than 7. And as you know, most people, almost no people have any symptoms until they have much higher A1Cs. So that's a way I use to describe the cardiovascular risk associated with type 2 diabetes, because that's the biggest risk that there is for type 2 diabetes. But I'm sure you're all going, yes, but there are other risks. And so what are those? It's really hard to get this information in a concrete way. But remember, I said a person who's got type 2 diabetes is, their 10-year risk is around 20%, for somewhere about 20, 22, 24. What about the risk of dialysis and blindness? Well, this is the best information I could find, and it's the lifetime risk, not 10-year risk, but lifetime risk of dialysis or blindness based on increasing A1Cs. You have about a 6% chance of clinical peripheral neuropathy over 10 years, but if you look at the risk of dialysis, it starts off at about 0.5% if your A1C is 7, and it goes up to about just over 2%. Lifetime risk of type 2 dialysis if your A1C is around 11. And blindness starts off at almost 0 if you're under 7, and it goes up to about 4%. So there's clearly risks associated with increased glucose. I'm not trying to suggest that's not the case at all, but I think it's important that we provide patients with a ballpark estimate of what the actual risks are so we can put it into context. And given that the vast majority of diabetics are actually even lower on that scale. So what I thought I'd do is just give you a brief synopsis. For the sake of time, I won't go over every point on it. But this is a synopsis of all the available evidence that we have for using treatments, for using medications to lower glucose. And what I've done is, I don't know if you can see it on that graph, hopefully you can, but at the top it's the impact it has on heart attacks and strokes, and then what it does to your eye and your kidney, and amputations and so on and so forth. And so the key RCTs are in the first column, and then if there's a meta-analysis of studies, it's in the second column. So metformin, we literally have one study. Now it's the UK PDS and it's everything that we hang our hat on, but it's one study and it showed about a 7% absolute reduction in cardiovascular endpoints over a period of 11 years. Interestingly, and I'll show you this later, there's a meta-analysis of all the studies that have ever been done of metformin, and they don't show a benefit in anything. We have the sulfonylureas, and the evidence of all the studies that we have to date, there's a 3% reduction in retinal photocoagulation. That's the benefit, that's the only benefit so far that we've seen from randomized controlled trials. And it just gets worse from there. All of these agents either have not been studied or the evidence is not showing that we reduce important cardiovascular endpoints. So this is of concern, and I think most people, I don't know if you realize this, but many of these medications either have studies showing no benefits. For instance, the DPP-4s have a number of studies that have looked at outcomes, and I'll show you some of those. They are not reducing the cardiovascular endpoints the way that we would like to see them. And as Tracy pointed out earlier, even tight control is tricky in that it doesn't appear to improve outcomes to the degree that I think many of you would believe. So this is why we're starting to see reports like this out in, for instance, Diabetes and Metabolism 2014, where they said they did a complete review of not the micro and macrovascular look at the evidence for the complications of type 2 diabetes and what happens when we give medications. And they're basically, we're saying that the evidence for the clinical efficacy of anti-diabetic drugs is disappointing and does not support the millions of prescriptions being written for them, which is really tricky. As I mentioned, the most recent meta-analysis of metformin, and I'm not saying not to use metformin, I'm just saying this is as good as the evidence that we have. This is the only meta-analysis that I've seen of metformin. They took all of the studies that have ever been done, and of studies that compared metformin to conventional treatment or placebo over 5 years. And a relative risk of 1 means no difference. So if it's really close to 1, it means no difference. Or if the confidence interval includes 1, it means it wasn't statistically significantly different. So mortality, 0.99, it means there's no change in mortality. Cardiovascular disease, MIs, strokes, heart failure, peripheral vascular disease, amputation, or microvascular disease. So we are using metformin on the single basis of 1 study, and it's the UK PDS. It's an okay design trial, but that's all it's based on, which is, I just find fascinating. So the UK PDS 34, we had a 10-year follow-up. So the UK PDS was the first trial that looked at use of metformin in newly diagnosed type 2 diabetics. But what's really interesting in this 10-year follow-up trial, which does show benefit, and it's one of the studies I use to say, if you're going to use anything, you should probably use metformin. It's based on 136 people getting metformin, which is not a lot of people, and that you can have oodles of problems associated with studies where you only have 136 people. Now, it did show fairly impressive benefits, and if it's real, it's encouraging. They showed that if you gave metformin and then for 10 years and then followed it up another 10 years, you could see about an 8% absolute reduction in any diabetes-related endpoints. You could see a reduction in deaths related to diabetes by about 5% and all-cause mortality. And so the UK PDS does clearly suggest that metformin has a benefit. But what's interesting in this study, they very rarely mention the fact that there was another arm to the trial where they added metformin to people who were already on sulfonylureas, and that increased death. But they don't mention that very often because it doesn't really fit the whole concept. These are some of the things that make me worry about the UK PDS, even though I think it is a useful trial for us to use. As I mentioned, only 342 patients got metformin in the whole place and overall, and 136 in the follow-up. It was unblinded. It's not easy to do blinded trials of type 2 diabetes. A number have been done, but it was unblinded. So any of the non-objective endpoints should be questionable, and there are a fair number of those. Interestingly, multiple outcomes are added during the study. So after a few years, they didn't find anything, so they added in a whole bunch of different outcomes and kept doing that until they found a difference, which is an interesting way to do a study. Only 78% of the people initially entered were analyzed, so there was a loss to follow-up. Interestingly, it's never been reproduced. And that's where, in all of science, that's what we try to do, is we try to reproduce the concepts before we really definitively hang our hats on certain things. And as I mentioned earlier, in the same study, the addition of metformin to sulfonylureas increased mortality. Probably about 9 years ago, there was a well-designed randomized controlled trial that compared metformin to rosiglitazone and glyburide. And whenever I looked at the study, I just kind of ignored it as much as I could because it didn't work for me, because then it would make the UK PDS look not all that good. But this was a well-designed study. This is the largest trial that's ever really looked at important endpoints. And they compared metformin to rosiglitazone to glyburide. It was a blinded randomized controlled trial of 4,500 patients for 4 years. And this is what they showed. For glyburide, mortality was the same all the way across the board for all 3 medications. Cardiovascular disease, the only difference was that glyburide, interestingly, reduced cardiovascular disease compared to rosiglitazone. Metformin did not. CHF, we know that the glitazones increased the chance of heart failure, and so they did, at least in comparison to glyburide. There were more GI side effects associated with metformin, which any of you who've ever used it, I'm sure, recognize that that can occur. There was more hypoglycemia in the glyburide group, that's typically what we see in people who are giving glyburide. There was more edema in the patients who got rosiglitazone than in the other two drugs. There was more weight gain with glyburide and with rosiglitazone, which is again what we typically see in practice. And there was no weight gain, or there was more weight gain with those 2 drugs than compared to metformin. And there were more fractures in the group that got rosiglitazone. So this is likely the best study from a study design perspective that's ever looked at what happens when we give these 3 different agents. Those 2 trials are almost identical in what they did. The A1Cs were the same going in. They were relatively newly diagnosed type 2 diabetics. Their average ages were consistent, relatively the same numbers of males, and so on and so forth. So it's hard to definitively hang your hat on the UK PDS when we have data that somewhat looks like this. For that reason, and for many reasons, in December 2014, an investigative group looked at the whole concept of the treatment of type 2 diabetes. And this is a true statement, we can't argue this, but from 2014 to 2013, none of the 30 new diabetes drugs that came on the market were proven to improve key outcomes. So they just didn't have any studies, or if they did, they didn't reduce outcomes. So that's of concern. And their 5 messages when they looked at all of the information for type 2 diabetes was this: diabetes drugs improve lab tests, but not much more, particularly in pre-diabetics. And pre-diabetes, we should never be treating that with a drug. It doesn't make any sense. Why would you treat a pre-diabetic with a drug to reduce a chance of becoming diabetic where they would need a drug? The logic is completely flawed. Treat 100% of people to reduce the chance that 20% might need a drug. There's no logic that I can think of anyway. There are, and I'm sure you've actually seen this, there have been a number of deaths associated with diabetes drugs, if just hypoglycemic episodes and hospitalizations and so on. I'm not into the whole conspiracy theory, but I'm sure there's millions of dollars around there. We now have the concept of diabetes being the risk of a risk now equals a disease. And the clinical threshold for diagnosing diabetes has crept lower and lower over the past decade.
Killing me softly with his song, killing me softly.
Who's that? You are a smart group and very old. From 1973, that's what she looked like then, that's what she looked like now. So, why did I put that up? Because of this, quality of life. There are all sorts of quality of life scales. I'm not saying this is the definitive way to look at quality of life, and I don't have a point here, but at the top is perfect health. If you look at all of these things that reduce health, now one can debate exercise and things like that should not necessarily worsen, but you can't be more perfect than perfect. So that's when you do exercise, I guess it doesn't increase your quality of life. Unless you weren't at a good quality of life, then it would increase it. So that's why exercise is a little bit lower. But I want you to look through some of these things that reduce quality of life. Death is 0. And just being completely naive and not knowing anything about the world is 1. I want you to see the thing in purple. Comprehensive diabetes care reduces the quality of life the equivalent of at least a mild stroke. This is not what your job is. I don't think you should do that. Oh, by the way, what we're going to do, we're going to enroll you into this whole program, and we've got to make sure you lower your glucose, and you know what? You're going to feel like you had a mild stroke. Not quite what we're looking for.
Oh, baby, baby.
Britney Spears, you're not as old as I thought. Well done. 2000. So why did I put that song up? Well, I find this fascinating. Alogliptin. This was published just a couple of years ago. This is, I don't know if you've ever heard of non-inferiority trials, but non-inferiority trials are trials that you usually do between 2 drugs to see if, want to make sure they're equally, they're just non-inferior, so they work the same way. The FDA is now requiring that drugs for type 2 diabetes have non-inferiority trials against placebo. You have to prove that your drug does not do more harm than placebo. So this was a study of alogliptin where they looked at using it for type 2 diabetes in people with acute coronary syndrome. In theory, if you give this drug, it's against placebo, it should lower cardiovascular outcomes, because that's your job. That's the job of giving the drug. Rates of death from cardiovascular causes, non-fatal MIs and non-fatal strokes that were similar to those of placebo. That's considered now a victory in type 2 diabetes management. The most recent trial that will come out in, I think, about a week and a half is called a TACOS or TICOS study. It's sitagliptin. It's 15,000 patients, type 2 diabetes and a history of heart disease, given for 3 years. This is a placebo-controlled trial. It's another one of these non-inferiority trials. And there was no significant difference in a composite of all the cardiovascular events that we worry about in type 2 diabetes. And I like this, no increase of risk of CHF, and doctors breathe a sigh of relief. So the reason they had to do this study was because they realized these drugs increase the risk of heart failure compared to doing nothing, and they're happy that it didn't do that. But it did nothing to any endpoints. And now 3 years, it's debatable about whether that's long enough, but it's frustrating.
Something so strong could carry us away.
Pardon? Crowded house, well done. I was going to be very disappointed in you all in a minute. Okay, so that's what they looked like then, and that's what they look like now. So something so strong. So the most recent type 2 diabetes guidelines just came out in January 2015. There was 2 documents. I loved it. Look at what it says, a patient-centered approach. I almost died and went to heaven. My quality of life was 1 when I saw that. It's 113 pages. So, and I'm sure you've all read it. I went through those, and there is, in 113 pages, no mention or discussion of the magnitude in relative or absolute terms of any adverse clinical endpoints associated with elevated glucose. It basically says glucose is bad. That's it. So you can't even use this to be, because patient-centered approach is giving benefits and harms. We then looked at the impact of treatment. There was no mention of the magnitude of benefit regards to retinopathy, kidney disease, and neuropathies. They mentioned a couple places on cardiovascular disease. It was all relative numbers, and there's no way, as a clinician, you could put it into context. Potential harms, they did mention the medications that are available, and they didn't list a whole bunch of the harms, which is really good. Unfortunately, there was, they only mentioned absolute numbers twice, so you couldn't even put context to it without having a ballpark numbers associated with it. That's 113 pages. And so we've written a letter to the editor of this journal, and that was about 3 or 4 months. We've had the letter accepted, but we haven't heard back how they're going to respond to this statement, because this is just not the way to do it. I could write you a type 2 diabetes guideline in about 1.5 pages to give you all the information that you needed to do that, and we just don't seem to do that.
Help, I need somebody.
What's that? Beatles, you should all know that, I hope. So that's the Beatles from 1965, and that's what they looked like when they were doing that. So this is my last slide, and I'd love to get comments and questions about it. I think this is my last slide anyway. So this is how the U.S. National Library of Medicine, or the NIH, refers to type 2 diabetes. It's a lifelong chronic disease. And the government of Canada says type 2 diabetes is one of the fastest growing diseases in Canada. These next few lines might be controversial, I don't know. I'll see what you guys think. We need to stop diagnosing people with the disease of type 2 diabetes. We need to, in my opinion, based on the fact that we can't do a lot. I mean, obviously, physical activity, improving how people eat, all those sorts of things, those are all great things to do. We all know that we got to do those things. What we should be just saying is your sugar is increased, just like we do with blood pressure or cholesterol. I don't know about you, but the stigma associated with being given a diagnosis of type 2 diabetes is fairly impressive. People don't go home and go, guess what I got today from the doctor? Diabetes. They don't do that. They don't do that with gonorrhea either, just in case you're wondering. I think we need to provide the risks with and without this increase in glucose and not create an emotional upheaval by giving them that diagnosis. We do it. Mom has, and not only that, we do it quietly. You know what? Mom has diabetes, just like they have cancer. Because we've given this sort of stigma. Or I've actually heard dad's diabetes is in remission. Really? We really should, here's what we should say. Dad doesn't have diabetes, he just eats too much and isn't active enough. Now, I know that's not everybody with type 2 diabetes, but it's the majority of people. And that would be a better way, I think, of saying it. And I don't think we should be describing type 2 diabetes as a yes or no condition. It's one of the problems that we have with type 2 diabetes. You have it or you don't. There are degrees, just like having a blood pressure of 141/91 is not nearly as bad as if your blood pressure is 230/140. I know you know that. And so what we need to do with diabetes is not use these arbitrary classifications. We just need to know this is your risk associated with this glucose. And there's a number of tools that can help you do that and put it into context. And I think that was my last slide. It was, and I'd be happy to answer any questions if I could do that. Thank you for listening.